So I have the pleasure of introducing Dr. Alan Sager. Dr. Sager is a professor of health policy and management at the Boston University School of Public Health. His courses in healthcare finance and planning have won 14 awards. His analysis of U.S. urban hospital closings over 85 years have shown that closings have harmed access while boosting costs. And he has described a way to hold down prescription drug prices and out-of-pocket costs while boosting incentives for innovative drug research. He will present on affordable medical security for all Americans is the easiest problem to fix. And at this time, I'll turn the floor over to Dr. Sager. Thank you.
Dr. Kavanaugh, thank you very much. Why don't we start with a quiz? I'm thinking of three big numbers with lots of zeros after each one. They're in a ratio of 1 to 2 to 5. So which one is healthcare spending? Which one is education? And which one is defense spending? So number one, the smallest, which one is that? Defense or education or healthcare? Anybody?
Probably education.
Okay. By a vote of 1 to 0, that's education. It was very democratic tonight. Which one is 2, twice as much as education?
Well, I'll guess defense.
Defense, okay. And so the big one, number 5, is, do you think that's healthcare? Well, unlike almost everybody, you've gotten one right. It turns out one is defense, around 800 to 850 billion a year now. 2 is education, about double defense spending. And 5 times defense spending is healthcare. Most reporters I talk with get all three wrong, and they typically think healthcare is the smallest. So congratulations. When I think that healthcare is the easiest problem to fix in the United States, I just mean it's easier than any of the others. And if we imagine that we fast forward to 2034, which, as you know, is 50 years after 1984, which was a good book. Imagine it's 2034 and we've fixed healthcare well enough. Not perfect, but still a lot of things to do, but healthcare is in much better shape. So we might ask, why and how did that happen? What spurred us to act, and how, concretely, what steps did we take? So it's good to start where we are, look backward from 2034. We can see signs of destabilization of US healthcare. COVID was certainly a factor that made things worse. It hurt doctors and nurses and other caregivers, and we still see nursing shortages at many hospitals, and especially at hospitals that have too little money to hire more nurses and attract more nurses. And COVID increased doctors' anger and alienation, resentment, speeded early retirements. And we continue to see financial destabilization, closings of urban hospitals and rural hospitals, and big cuts in nursing home capacity. And right now, we see Medicaid recertifications throwing millions, about 3 million people so far, off the Medicaid rolls, overwhelmingly for administrative reasons, where people who are still, in fact, entitled to coverage have been thrown off. A second kind of destabilization is how crazy the world is. We see Ukraine, we see Taiwan, we see Iran. All of these are factors that have begun to and will continue, I think, to lead to pressure to increase defense spending. Third, risk of inflation, risk of recession, the rising national debt. Before the financial crisis of 2007, 2009, the debt was below 10 trillion. It's well over 30 trillion now and continuing to rise. Congress has begun to convince itself that it won't be possible to do anything about federal deficits or the debt if they want to, simply by focusing on non-defense discretionary spending. And therefore, there will be attention to Medicare and Medicaid, especially Medicare, even though Congress won't happily try to rein in Medicare spending. I think they'll be forced to try to do that. At the same time, I think more and more hospitals and doctors have come to recognize that more money for business as usual in US healthcare isn't sustainable. We're at $4.7 trillion this year for healthcare, 17–18% of the economy predicted to rise to 20% or more. And healthcare spending in an average year sponges up 30% of economic growth. So healthcare spending may be crowding out other things we care about. And we're not getting our money's worth for all the money we spend on healthcare. So it's likely that more money to finance business as usual in US healthcare will stop flowing. We'll see federal government less willing or able to boost Medicare and Medicaid spending. Defense pressures, we're trying to return manufacturing, address infrastructure, financing higher interest on higher national debt, resistance in many quarters to higher taxes. State governments, many of them are anxious to tighten their spending on Medicaid. And private employers have reason to worry that if Medicare and Medicaid spending slows down, hospitals and doctors will try to push private insurance companies paid by employers and employees to shoulder more of the cost burden. That doctors and hospitals, drug companies will try to extract higher prices from privately insured patients, which will boost premiums. And employers are beginning to recognize, I think, that insurance companies have no effective tools to do anything real about cost. They can raise out-of-pockets, they can form narrow networks, but those are both fool's games. Caregivers face financial and legitimacy crises. Many hospitals fear bankruptcy. Many doctors already face income loss and fear greater income loss and hamstrung autonomy. Both hospitals and doctors, many of them, fear harms to patients, and so do nurses and other caregivers. And I think more and more caregivers, professional and institutional, will drift toward compromise and reform. Patients may well be increasingly frightened by more crowded emergency rooms, higher out-of-pocket payments, and the growing shortage of primary care. And I think recognition will grow that it's no longer affordable to waste 1/2 of healthcare spending on care that doesn't work or isn't needed, paperwork, high prices, and theft. We'll see responses, I think, from public and private payers, especially when rural hospital closings worry red state politicians. It may be that in Mississippi, where they have an election for governor in November, the biggest issue may be Medicaid expansion, where rural hospitals have been closing and the governor and the state legislature refuse to accept $1 billion a year in money raised overwhelmingly in blue states. At the same time, urban healthcare inequities will worry blue state politicians. Big hospital closing in Atlanta, another in Cleveland, a number of other cities, St. Louis, face hospital closing problems. There'll be a consensus, I think, that Medicare in Congress and Medicaid, Congress and the states, and employers will come to consensus on the need for actual effective action to contain cost growth. We've never had that in the United States, but I think we're heading toward that. At the same time, as many people want to contain cost, people recognize that caregiver cuts and cost containment closings of hospitals, loss of primary care doctors, combined with cost containment, if it gets real, will disproportionately harm poor people unless the cost containment is accompanied by solid coverage for everyone. And I think the most reasonable arrangement that is both effective and politically possible would be something like the old New York State Unicare proposal, where people kept their insurance card, but gradually all payers paid the same price. So that might be an umbrella approach for all payer coverage and financing. I think fourth steps will become reasonable in most people's eyes. Capping cost, capping spending, covering all people well, paying caregivers, especially doctors and hospitals, in ways that are commensurate with cost caps and healthcare for all. And these are the three steps that every other rich democracy has taken. Cap cost, cover everyone, pay caregivers in ways that respect covering everyone, serving everyone, and capping cost. A fourth step, more important in the US than elsewhere, is to sustain, retain, or obtain the right numbers and types of doctors and hospitals in the right places, and nurses and dentists and other caregivers. Under this idea of a New York State Unicare proposal, total revenue for healthcare would be pooled and capped, a national cap on spending that would translate into state caps. Employer insurance premiums per worker would be capped in today's dollars at today's levels. All added spending would be financed with tax dollars, which is both more equitable, because insurance premiums are really a regressive way of raising money. But using tax dollars to finance all added spending is both more equitable and is powerful political pressure to hold down spending growth. All the different streams of revenue are channeled into one reservoir, and that money backs all citizens' healthcare cards. Current forms of coverage, like Medicare or Blue Cross Blue Shield, would persist for a while. People would have cards that look different, but all cards would now have the same benefits, the same coverage, and all would pay caregivers at the same prices for the same care. Out-of-pocket payments, deductibles, co-payments, co-insurance, out-of-pocket maximums would be frozen in nominal dollars of 2023 and then gradually cut back. To make caregivers revenue and reconcile that revenue with national and state pools of money, payment would have to be changed. Hospitals would transition to rigid, static, Veterans Administration style budgets. Doctors working in hospitals would transition to high salaries, probably higher than today's average incomes, but they would be on salary. And doctors working in hospitals would allocate hospital budgets, but would themselves be financially neutral. They would have no upside risk of gaining money by denying care, and they would face no downside risk of overspending because they wouldn't be able to overspend the budget. You can only spend what's in the checking account. Doctors in ambulatory practice would probably continue to be paid fee for service, but fees would be set not by a Medicare RBRVS fantasy formula, but rather with a goal orientation where the goal is to allow a hardworking doctor to earn a target income. And that target income would be negotiated between doctors and payers. New drugs would be approved if safe and effective and affordable, with profit and development costs paid by prizes financed equitably by rich nations. So innovation is still incentivized, but the cost of innovation, the cost of research and profit and making the first pill, would be kept out of the price of the pill, making, therefore, meds that are safe and effective affordable for everyone. So how do we reconcile national and state pools of money with patients' needs and expectations, and at the same time with doctors' own training? Well, chopping waste, especially paperwork waste, and clinical waste, care that doesn't work or isn't needed, liberates a lot of money, but still not enough to do everything that might work for anyone who might need or want it. Dollars are finite, pathology is remorseless. Just as prevention has a 100% failure rate, so does healthcare. And I think the aim of healthcare is probably not immortality, but rather competent, quick, kind, and fair care without imposing charges on sick people or bankrupting people or garnishing wages. So we have to spend money effectively and fairly. And we can ask then, what are the roles of doctors and patients, maybe even lawyers? Well, we will reform configuration of caregivers, how many, what kind, and where they're located. Each needed hospital would be paid enough to finance efficient delivery of needed types and amounts of care. That requires assessing which hospitals are needed and the cost of efficient delivery of needed care. The state of Maryland has been going toward this for 50 years. They have a lot of expertise and experience and sophistication, both financially and politically. A second step would be big expansion of primary care through higher incomes and cuts in panel size from today's 2,000 to 3,000 average to about 1,000. So primary physicians would have time to think, talk with patients, answer phone calls and texts, and even visit patients in the hospital. Time to build trust with patients, to assure continuity and coordination of care, and to weed out wasted services. There are going to be political and clinical and money and legal and ethical elements supporting payer-caregiver peace treaties. An enormous cut in doctors' money-related paperwork. Even EPIC, when it's used in countries with real healthcare, requires a fraction of the number of doctor or nurse keystrokes to sustain the medical record. I see an end of prior authorization for in-hospital care, an end of malpractice litigation. All patients are insured against health costs. All would have short-term disability coverage for lost income, and pain and suffering would be arbitrated. At the same time, a massive cut in nurse documentation at the bedside and a cut in other administrative work for nurses, liberating more time to care for patients at bedside. For reasons I'll get into, for-profit healthcare doesn't work, so it'll be necessary to buy out for-profit hospitals, ambulatory surgery centers, other caregivers, and insurance companies. Since no competitive market in healthcare legitimizes profits, we're going to prohibit for-profit ownership of clinical care facilities or caregivers. Since we can't take property without due process, we'll compensate the owners. For example, if we look at the 3 biggest for-profit hospital chains and the 7 biggest insurers and PBMs and others, if we bought them out, the current value of all of their stock is about $900 billion. That may sound like a lot of money, but we'll give them bonds for $900 billion, pay them 5% interest for 20 years, and then we'll redeem the bonds after 20 years at a time when the cost of the $900 billion will be much lower. If we think for-profit operators today have management expertise that cannot be developed internally or bought or hired, we might contract with some of the for-profit operators. So I see that happening by 2034. Coming back to the world today, we already spend enough to finance medical security for all Americans. The 4.7 trillion is enough. there's real evidence that that's true. US healthcare is financially addicted to more money each year to pay for business as usual. Each year, the added 1/5 to 1/4 of $1 trillion in new money does absorb 30% and rising every year of all economic growth. This means that 3 or 4 years of the increases in healthcare spending combine to equal 1 year's defense spending. The money in healthcare is astonishing. Now, at the same time, some payers are becoming unable and unwilling to provide the added money that caregivers have become addicted to. This is a matter of when the money ceases to flow, not if. We will suffer less if we prepare now to protect patients and caregivers during the immediate crisis and to reform healthcare financing and delivery quickly when the crisis hits. And there's been some thinking about that, but not remotely enough. So why don't we already have affordable, high-quality healthcare for all that covers everyone, contains cost, pay caregivers and hospitals commensurately with coverage and cost control, and to configure our doctors and hospitals and dentists to be where they're needed in the right amounts, and to make quality of care more equitable? Every other rich democracy does these better, more or less, in ways that look very different from how we do things, and very different from one another, at least on the surface. But in the other rich democracies, make similar parallel decisions about the 5 questions. Now, I hope you can memorize these numbers very quickly because all this will be on the final exam. The point of this chart is that when we compare US versus other rich democracies in the Organization for Economic Cooperation and Development, between 1970 and 2019, 2020, the latest, we see that health as a share of the economy was 30% greater in the US in 1970, but now it's 70% greater. Spending per person was 1.8 times as great in the US in 1970. Now it's 2.1 times as great. The US had fewer beds per 1,000 people, 90% as many in 1970, but now it's only 60% as many. We used to discharge more patients from the hospital, 20% more. Now we discharge 20% fewer. Life expectancy at birth used to be a little better in the US. Now it's a little worse. And potential years of life lost, slightly worse, now 50% worse. So by all measures of cost, care, and healthcare outcomes, longevity, the US has deteriorated relative to other rich democracies in the last 40 years. If we want medical security for everyone, competent, quick, kind, and fair care without worrying about the bill, we should consider 3 levels: financial coverage, the plastic insurance card, staple to everybody's collar; doctors and hospitals nearby who are willing and able to redeem our card and care for us; and third, equitable, appropriate, and high-quality care for everyone. Financial coverage is the easiest of the 3 problems. Equitable and appropriate, high-quality care for everyone is the hardest. I think that reforming healthcare is strategic. Some people say, and probably everyone on this call today probably thinks, that spending more money on social determinants of life, housing, income, job training, employment, nutrition, environment, and others would do enormous good in advancing health. But I think that regardless of your desire or mine to spend money on social determinants of life, and regardless of whether we know how to spend that money effectively, I think that hoping for more money, serious money, to spend on social determinants of life is a fantasy, unless we can stop healthcare from sponging up an added 1/5 or 1/4 of $1 trillion every year Also, even worse, focusing on social determinants of life today can and does have the effect of letting healthcare off the hook because it becomes a distraction. The money won't be available, but fighting for that money, I think, will distract attention from fixing healthcare itself. And it'll enable more money to continue to flow for business as usual, delaying the day when reality strikes healthcare. So, reforming healthcare is hard. We don't have a functioning competitive free market in healthcare, but Americans tend to believe in the market. And investors who lack good investment opportunities outside healthcare crave more opportunity to parasitically pillage and plunder healthcare. But just as we have no competent free market, we lack competent government action. Also, Americans have little trust in government, and monopolies and bureaucracies rarely work well for humans who are forced to rely on them. So more money for business as usual remains a lowest common financial and political denominator until we run out of money. And that's what we have to prepare for when we run out of money. These are reasons why there's no competitive free market. Not one of the 7 requirements for the market is remotely satisfied. But there's still the romance of the market, where we have efficient sellers who innovate to cut cost, and they can't make money unless they make what people want to buy. So the free market is self-regulating, and government has to only police the market to guard against corruption and to break up monopolies. And the invisible hand converts the greed for profit into efficiency and goodness. But without a functioning free market, profits don't signify that you're doing a good job. They mean they are actually profits without honor. At the same time that we lack a market, we don't have competent government action. Government in the US is unwilling to cover everyone, unwilling to contain cost, unwilling to regulate, and unable to regulate effective responses to all the abuses thrown up by a failed market. And government can't conceive of competently addressing caregiver configuration today, the right numbers and types of doctors and dentists or nurses or hospitals in the right places. So A is for anarchy. Anarchy is what you get when there's no functioning competitive market or competent government action. Chaos, anarchy. No one in healthcare is financially or clinically accountable for anything that happens outside the building where they work. And anarchy is how our nation fails to cover everyone, gives less care to fewer people, at double the rich democracy average cost, and dies younger. So here's a quick checklist of steps that I believe we will take by 2034 toward clinical and financial accountability. And this means no reliance on financial incentives or bribes to change doctor or dentist or hospital or hospice or nursing home behavior. All caregivers are nonprofit. Doctors are made financially neutral by salaries or by fees designed to generate target incomes. Doctors and hospitals, other organized caregivers, become fiduciaries who are given the freedom to expend finite money and time to maximize patient well-being. Theft kills, so punishments for stealing are harsh. Waste kills, so evidence on clinical value of different medical and surgical treatments has to be compiled and respected. Incompetence kills, so dangerous clinicians have to either improve or cease working in healthcare. Many Americans value choice, but what types and degrees of choice are reasonable or politically necessary or affordable? Now, one option would be complete patient freedom of choice of all caregivers, as we see in Canada or France. Alternatively, everyone could be invited or obliged to sign up with one of 3 or 4 competing nonprofit HMOs in their region. All HMOs are paid the same risk-adjusted capitation rates, no profit, no marketing. Each has to spend its whole budget yearly. Each might employ its own doctors and hospitals or contract with them. A remaining question would be, should patients be allowed to demand publicly paid care when solid evidence shows it is too costly or too low in clinical value? So, money is finite, pathology is remorseless. The only reason to deny care to any patient in this new world is to liberate clinical time and money to serve another patient who'd benefit more. If money is finite, healthcare theft manifestly kills. It's no longer a victimless crime. I don't know if you recognize the politician on the left, that's Senator Rick Scott of Florida. And that apparently is a photograph of Voldemort. These two individuals have never been seen together. Healthcare theft or plundering is not a crime of poverty or a crime of impulse, and it's something worth addressing. A big remaining problem will be how to craft governance for nonprofit hospitals so that their trustees, who often don't do great jobs today, can become trustworthy fiduciaries who are dedicated to getting as much care as possible, care that works to patients who need it. A key element will be to get serious about primary care. If we want one primary for every 1,000 Americans, we'd need about 340,000 full-time equivalent primaries. If we pay them $500,000 each, salary plus fringe benefits, that's $170 billion a year, which is only 3.6% of this year's health spending. We can afford that, and we'd save money if we did that. Getting to that will take time. We need to recruit medical students who value both the science and the relationships, and who are mentally tough enough to take on the most challenging job in medicine, since they have to know a lot about a lot of things. To get rural primaries, we need to embed people who are recruited locally and hope they'll return to family and friends and hunting and fishing or hiking in rural areas. Adding nurse practitioners and physician assistants would be useful, but if we allow doctors to exit primary care, they'll all be ologists and we won't be walking around with any of the organs we were born with. We have only 3/4 as many doctors per 1,000 citizens as the rich democracy average. The entire American shortfall is in primary care, so we have to do something about that. We have to get serious about meds and about long-term care. But after we cover everyone and contain cost and have the right caregivers in the right place, quality challenges would persist. And I'm going to end on the most difficult problem. Lower income people are today disproportionately served, not always, but disproportionately, by lower quality hospitals and doctors, nursing homes, and hospices. The extent is hard to measure. The causes are subject to some evidence, some speculation. The remedies for inequitable quality are close to invisible today, but it won't hurt to start anticipating how to address those inequities. And thank you very much for the chance to speak with you.